So students, let us come to the lowermost part of the pharynx, that is also known as hypopharynx, or we can also call it as laryngopharynx. So it is the lowermost part, it is known as hypo. Hypo means the lower part. It is around and behind the larynx, so it is also known as laryngopharynx. Let's look at this diagram. Now in this diagram, you can see that this is the epiglottis. You can identify the hyoid bone in front of the epiglottis. And you can also see the cricoid cartilage. Now we know that from the level of hyoid bone superiorly to the lower end of cricoid cartilage, we have over here the hypopharynx, right? So that's the hypopharynx, behind and around the larynx. And below the lower end of cricoid cartilage starts the esophagus. So that's at the level of C6 cervical vertebra that the lower end of cricoid cartilage lies, and from here starts the esophagus. Okay, right. Let us look over here in this pharyngeal wall. So remember this diagram we discussed when we discussed the wall of the pharynx, the pharyngeal wall. And we know that the pharyngeal wall is formed by three constrictor muscles. Which three constrictor muscles? Superior constrictor, middle constrictor, inferior constrictor. Remember we have discussed this, that there are three constrictor muscles, superior, middle, inferior. All these three constrictor muscles, you see they are attached to a structure anteriorly. So they are open anteriorly, they are attached to a structure anteriorly, then they go all around and they fuse posteriorly with each other in the midline pharyngeal raphe. Right? Okay. We also discussed the nerve supply. So now all these muscles, they're supplied by vagus, 10th cranial nerve. Now vagus has two terminal branches, superior laryngeal nerve and recurrent laryngeal nerve. All these three muscles, they are supplied by superior laryngeal nerve. Okay, over here I would like to point out that the nerve supplying them is vagus. Okay, but in the pharynx, the vagus forms the 10th cranial nerves. It forms an anastomosis with the 11th cranial nerve, that is the accessory nerve. Okay, so that is known as vagus accessory anastomosis. Okay, now this vagus accessory complex, from here the accessory nerve gives its fiber to the vagus. Okay, and through the superior laryngeal nerve, they come and supply these constrictor muscles. All right. So if somebody asks you which nerve is supplying these constrictor muscles, answer is vagus. Okay. If it is asked which this vagus nerve which is supplying the constrictor muscle is carrying fibers of. So if this word is asked, so remember it is carrying the fibers of the 11th, the accessory nerve. Okay, now over here there is one thing different. You see the inferior constrictor muscle, it arises from two different cartilages. Which different cartilages? Thyroid cartilage, you can see over here, and we have the cricoid cartilage. So the inferior constrictor muscle is divided into two parts. Which two parts? We have the thyropharyngeus. So the part that arises from the thyroid cartilage is known as thyropharyngeus, and the part that arises from the cricoid cartilage, that is known as cricopharyngeus. Right? So we have thyropharyngeus and cricopharyngeus. Now remember, as I said, all these muscles are supplied by superior laryngeal nerve. That was true for all muscles, including inferior constrictor, except the cricopharyngeus. Remember, the cricopharyngeus, it is supplied by recurrent laryngeal nerve. Okay, so it is out of this complex also, it is supplied by the recurrent laryngeal nerve, the cricopharyngeus muscle. Right? Okay. So all the remaining are supplied by superior except the cricopharyngeus. And yes, if you say all of them are supplied by the vagus, because both superior and recurrent, they are branches of vagus, 10th cranial nerve. Okay, right. Next, let's look over here in this diagram. Now what do you see in this diagram? You can see over here the thyropharynges. Now the thyropharynges, if you observe, when it is going to meet in the pharyngeal raphe, it has these oblique fibers. Right? Now when you see the cricopharynges, look at the cricopharynges. The cricopharynges, as you notice, has transverse fibers. So the cricopharynges has transverse fibers, whereas the thyropharynges has oblique fibers. Now because of this arrangement of fibers, there is a triangular gap created. So this is an anatomical place of weakness. This triangle, this is an anatomical place of weakness in the posterior pharyngeal wall, okay, and this is known as Killian's dehiscence, right? So this triangular gap is between the oblique fibers of thyropharynges and the transverse fibers of cricopharynges. Remember, Killian's dehiscence is also known as gateway of tears. Okay, why it is known as gateway of tears? You see, Killian's dehiscence is the most common site for perforation, esophageal perforation. Okay, it is the most common site for esophageal perforation. Remember, just below this cricopharynges, we have the esophagus. So the esophageal perforation starts from here. Right? What is the most common cause for esophageal perforation? So the most common cause is iatrogenic. The most common cause for esophageal perforation is iatrogenic, and with iatrogenic I mean esophagoscopy. Okay, that is esophagoscopy. So while doing esophagoscopy, if the surgeon is in a hurry, so he's trying to push his esophagoscope into the esophagus, and let's say the cricopharyngeus muscle is still in spasm, it has not relaxed. The muscle relaxant is incomplete, the anesthesia is incomplete, patient is still in the superficial plane, or sometimes it does take time for cricopharyngeus to relax. So the cricopharyngeus has not yet relaxed, and the surgeon is in a hurry, is trying to push his esophagoscope into the esophagus, and because this muscle is not relaxed, the esophagoscope goes through this Killian's dehiscence and creates a tear. Okay, because it creates a tear, from here the tear into the esophagus starts, it is known as gateway of tears. Right? Remember, the tears over here denotes the torn esophagus. It does not mean the lacrimal tears, because this question is asked in the exam. Why I am highlighting this? Gateway of tears is, this is the question, gateway of tears is, and the first option given to you is nasolacrimal duct. So remember, over here these tears does not mean the lacrimal tears. This tear over here means that the esophagus is torn and the tear starts at the Killian's dehiscence. Right? Okay. So English language, don't get confused. There are two types of tears and we are not talking about the lacrimal tears over here. Right? Other than this Killian's dehiscence, we can see that there is another anatomical gap where between the oblique and the transverse fibers of cricopharynges. Okay, so between the oblique and transverse fibers of cricopharynges, on the lateral aspect, of course, we have a anatomical weakness area that is known as Killian-Jamieson's area. Then between the circular fibers of the esophagus and the cricopharyngeus transverse fibers, we have another anatomical gap that is known as Lammer's dehiscence. Okay, so that's known as Lammer's dehiscence. So there are other places of weaknesses in the esophagus also. Now let us come to a disease known as Zenker's diverticulum or Pulsion diverticulum. We have understood the anatomy. Now you see what happens. When we eat, when we try to swallow the food that we have eaten, the thyropharyngeus contracts. Now when the thyropharyngeus contracts, it pushes the food down into the esophagus. Now for that phenomena to happen, the cricopharyngeus has to relax. Okay, so you see the thyropharyngeus contracts, at the same time the cricopharyngeus relaxes and the food goes down into the esophagus. but let's say both of them, they start contracting at the same time. Okay, both of them start contracting at the same time, or let's say the cricopharyngeus is in a chronic state of contraction. So what happens? The thyropharyngeus is contracting, trying to push the food down. The food, however, is not going into the esophagus. What will happen? Now, this food will push this anatomical weak area, that is the Killian's dehiscence, and it will come out forming a pouch in the posterior pharyngeal wall. This pouch is known as Zenker's diverticulum or Pulcian diverticulum, or even known as hypopharyngeal pouch. Okay, so the hypopharyngeal pouch or the Zenker's diverticulum or Pulcian diverticulum is formed, most common location is Killian's dehiscence. So as you can see over here, the most common location is Killian's dehiscence. Right? Now, the most common cause for formation of Zenker's diverticulum, I just told you, is in coordination between the two muscles, thyropharyngeus, which is supplied by superior laryngeal nerve, and cricopharyngeus, which is supplied by recurrent laryngeal nerve. So ideally, thyropharyngeus contracts, cricopharyngeus relaxes. Now if they start contracting at the same time, or the cricopharyngeus does not relaxes at all, it is not coordinating with thyropharyngeus, so then in that scenario we will have a Zenker's or a Pulcian diverticulum. Right? Okay. Now remember, the Killian's dehiscence is the most common location for development of Zenker's diverticulum, but that's not the only location. That's the most common location, but that's not the only location. Okay. Why? We discussed there are three anatomical places of weakness. Number one, I told you, was Killian's dehiscence, most common. Other than that, we can also have a diverticulum at the lemmus dehiscence. Remember, between the transverse fibers of cricopharyngeus and the uppermost circular fibers of esophagus. Okay, so transverse fibers of cricopharyngeus and uppermost circular fibers of esophagus. So we have anatomical weakness known as lemmus dehiscence. Right? And we can also have the development at the lateral aspect. Remember, we have the Killian-Jamieson's triangle, and that is the place between the transverse and the oblique fibers of cricopharyngeus. So on the side, when they are coming from the cricoid, there are some transverse fibers and some oblique fibers. In between them, we have the Killian-Jamieson's triangle. So Zenker's diverticulum can arise from any of these three places. Most common location is Killian's dehiscence. Now on this, a question was recently asked in the exam. Pharyngeal pouch is located between. So we know the most common answer, the best answer is Killian's dehiscence, that is between thyropharyngeus and cricopharyngeus. Okay, unfortunately this option is not in the answer. You see, thyroid and cricoid is a wrong answer, superior and middle constrictor is a wrong answer, middle and inferior constrictor is also a wrong answer. Now, if Killian's dehiscence is not there, that is not in the option, what can we go for? We can go for the lemmus dehiscence. The lemmus dehiscence is between the cricopharyngeus, which is a part of inferior constrictor, and esophagus. So this option, among the given choices, this option is the best answer that we have. Okay, so this is our answer. We are considering that it may be arising from lemmus dehiscence, right? Okay, so that can be the answer to this question. The remaining three options are obviously absolutely wrong. Okay, now how will a patient of Zenker's diverticulum present? Now Zenker's diverticulum patients are generally male patients, and they are in the age group of 60 to 70 years age. The patient, you see, the food is not going into the esophagus. So what is happening? The patient is having dysphagia. He is not able to swallow the food. Patient has dysphagia. Okay, where is the food going? The food is going into the pouch. What will happen to this food? This food will undergo decomposition. So when it undergoes decomposition, it gives a foul smell. The foul smell comes from the mouth. So patient has halitosis. Okay, halitosis means foul smell coming from the mouth. So patient has halitosis, that is the foul smell because of decomposition of food. And number 3, the patient has, you see the food is there in the pouch. When the patient goes to sleep, what will happen? The muscles relax. Now the food comes out. So patient has regurgitation, very important. Okay, very, very important and typical sign, regurgitation of old eaten food. So old eaten food at night time. So when the patient goes to sleep, this food comes out. So there is a regurgitation of old eaten food at night time. So that is very, very typical for the hypopharyngeal pouch or the Zenker's diverticulum. Now, how can you confirm your diagnosis? Patient comes to you with these 3. How can you confirm? You will do a barium swallow. Okay, so what do? You do a barium swallow. So when you do a barium swallow, what do you see over here? You can see a well demarcated pouch. Okay, you can see a well demarcated pouch. Look over in the second photograph. You can see this pouch. This pouch is arising from the pharynx. It is just behind the esophagus. You can see that this is the esophagus. So it is just behind the esophagus. So that is known as pharyngoesophageal pouch. Okay, so that is a pharyngoesophageal pouch. Starts from pharynx and it is behind the esophagus. So pharyngoesophageal pouch. Now, other than the pouch, what else can we see in the barium swallow? So we have confirmed our diagnosis. Can it help us find something else? Yes, it can. You see, this pouch is having retained food. So because of chronic irritation, it can develop inside it squamous cell carcinoma. So there can be development of squamous cell carcinoma in the pouch. Approximately 10% cases, they develop squamous cell carcinoma in the pouch, right? Can we find out about the squamous cell carcinoma with the barium swallow? Yes, it can help us in finding that. It can help us suspect the formation of squamous cell carcinoma. How can it help? You see over here, if this pouch is having a smooth wall like the one over here. So you see, this wall is a smooth wall that usually rules out squamous cell carcinoma. Why? Because if there is a squamous cell carcinoma present, there will be a filling defect. So if there is a malignancy, that will show as a filling defect on the barium swallow. But some of my friends will say, sir, if a food particle is there, that will also present as a filling defect. I'll say, yes, you are very right. Very good. If there is a food particle, that will also present as a filling defect. So how can you differentiate that filling defect is because of food material or it is because of squamous cell carcinoma? There is some growth. So there are 2 ways. One, you can do a repeat barium swallow. Suppose you repeat a barium swallow after some time. Now the food particle is supposed to move. Okay, so it will move from its place. But if this filling defect is a constant, it's a permanent defect, now that will raise my suspicion for squamous cell carcinoma. Okay, so filling defect means the contrast will not be there. Alright, the margin, the wall will appear a rough wall. It will not be a smooth wall, there will be some rough wall. So that's a filling defect, and that shows it can be a squamous cell carcinoma, especially if it's a constant filling defect. Okay, so instead of repeating the barium swallow, what we can also do is we can do a video fluoroscopy. So that's like a dynamic imaging, and you can see the actual movement of the food particle if it is there. So movement is present, it almost confirmed it's a food particle. No movement, your suspicion for the malignancy further increases. Now how can you confirm? Okay, you can confirm it by doing esophagoscopy. You can confirm that by doing esophagoscopy. Now you see over here, I would like to point out to you that the esophagoscopy is contraindicated for Zenker's diverticulum. Let me explain my statement. Suppose you suspect a Zenker's diverticulum. You suspect a Zenker's diverticulum. You will not do esophagoscopy. Okay. Why? Because while doing esophagoscopy, you may enter into Zenker's diverticulum and you may puncture it. You may cause a perforation. So you will not do esophagoscopy to diagnose Zenker's diverticulum. What we do to diagnose Zenker's diverticulum? We do a barium swallow. Okay. Now let me say once again. Suppose you have a confirmed case of Zenker's diverticulum. So now you have done a barium swallow, you have done a video fluoroscopy, you have a confirmed case of Zenker's diverticulum, and you suspect a malignancy inside the Zenker's diverticulum. Okay, now what you have to do? Now you have to do esophagoscopy. Now this is investigation of choice if you suspect a malignancy in Zenker's diverticulum. I hope you are understanding my point. To diagnose Zenker's, it's contraindicated. But if you suspect malignancy in an already diagnosed Zenker's diverticulum, then this becomes the investigation of choice. Why? Not only you can see the malignancy, but you can even take the biopsy of this malignancy while doing a esophagoscopy, and that's how it becomes the investigation of choice. Right? Okay. What is the treatment for Zenker's diverticulum? Now, for treatment, we have a lot of different options. What options do we have? Number one, I can go and excise the pouch. Okay. Now, this option is generally meant for a large pouch. Why? Why? Because you have to do a big neck surgery. You have to cut the neck. Then you have to separate all the muscles. Then you have to go, there are big vessels. There is IJV, ICA, there are cranial nerves, 9th, 10th, 11th, 12th nerves. You have to go all across them, the sympathetic chain. Then you reach near the pharynx. And then you have to take out the pouch. So it is going to be a big exercise. Right? So excision of pouch is done only when the pouch is very, very large. For smaller pouch, we would like to do something that is more conservative. Okay, so what conservative procedures can we do? What conservative procedures can we do? The conservative procedure that we can do is, we can do a cricopharyngeal myotomy. So what is this? You see, the cricopharyngeal muscle is in spasm. So you cut the muscle and you relax it. You release the spasm. Cricopharyngeal myotomy. Okay. Now generally this cricopharyngeal myotomy is done at the time of excising the pouch. Okay. It is also usually an external surgery. Sometimes you can also do endoscopically. But what about the pouch? Okay. So the most commonly done procedure that takes care of everything is the endoscopic procedure known as Dolman's operation. So what we do in Dolman's operation? You see, we have a pharyngoesophageal pouch. So what we do is, we go and we cut the intervening wall. The intervening wall between the pouch and the esophagus. So that is cut. And now this cavity is made a part of esophagus. So problem solved. Okay. You see, whatever goes into the pouch will automatically reach the esophagus. You have cut the intervening wall. So when you cut the wall, earlier we used to do endoscopic diathermy. So we used to seal this with the help of cautery, that is diathermy. Nowadays, instead of diathermy, we have something better. We do endoscopic stapling. Okay, so we do the stapling of the wall. Which wall? The intervening wall which we have cut. right? So that is known as Dolman's operation. Now remember over here, what is the principle of Dolman's operation? The principle is that you have to remove the intervening wall. Okay, now that is very, very important. You have to remove the intervening wall between the pouch and the esophagus. So that you can do with diathermy or you can do with stapling. Okay, if it is a very, very small pouch, I can just go and staple the mouth of the pouch. I can staple the Killian's dehiscence. Now that will not be known as Dolman's operation. That may be endoscopic stapling of the mouth of the pouch of the Killian's dehiscence, but that is not Dolman's. Dolman's is when you remove the intervening wall, you can use the staple for that. Okay, so that is Dolman's operation. And we had a question in the NEET PG January 2019. Dolman's surgery in Zenker's diverticulum. Endoscopic stapling of the septum. You see, of the septum, that appears as a correct answer. Let's look at the other option. Endoscopic suturing of the pouch, that is not Dolman's operation. Resection of pouch is also not Dolman's. Laser division of pouch, that is also not Dolman. Although you can use laser, but we try to avoid laser in the esophagus because the laser will cut and it will go ahead and cause injury to other structures. So we generally avoid laser for doing a Dolman's surgery. Okay, so it is endoscopic stapling of the septum. Anyways, over here the word used is pouch, so that is wrong. If they would have used laser cutting of the septum, we would have still accepted that as Dolman, but over here septum is considered only for one choice, that is the answer, right? So our answer is endoscopic stapling of septum. Okay, now before we finish the topic of the Zenker's diverticulum, let us look at the Zenker's diverticulum and the epiphrenic diverticulum. So remember, very easy, the Zenker's diverticulum, it arises at the start of the esophagus. Okay, at the start of the esophagus, upper part, whereas the epiphrenic diverticulum, it starts before the gastroesophageal junction. So that is lower down in the lower 1/3 of the esophagus. So clear, you can differentiate between Zenker and epiphrenic diverticulum. No confusion over here. Let's look at this diverticulum. Now this is a traction diverticulum. The best example for a traction diverticulum of the esophagus is, let's say there is a mediastinal lymph node. Okay, and this mediastinal lymph node gets inflamed because of some disease, or let's say tuberculosis, and afterwards it undergoes fibrosis. So because of the inflammation, it gets adhered to the esophagus and then it pulls the esophagus while undergoing fibrosis. So the esophagus goes forward and forms a traction diverticulum. Okay, so this is a traction diverticulum. Something has pulled the esophagus forward. Okay, now look at this diagram. When there is a traction diverticulum, when something has pulled the esophagus from outside, this pulls all the layers of the esophagus. Okay, so this is a true diverticulum. It has all the layers. So the traction diverticulum is a true diverticulum. You can see all the layers of the esophagus are there. However, the Zenker's diverticulum we discussed, it goes between the layers of cricopharyngeus and thyropharyngeus. So it does not have the muscle in it. It is a pseudo diverticulum. Okay, so Zenker's diverticulum is a pseudo diverticulum. All right, the traction diverticulum that I have shown you here is the true diverticulum. Right? Okay, now that was the wall of the hypopharynx. Let us go inside the hypopharynx. Okay, so this is the diagram of pharynx. We are looking at a posterior view. We are looking at the pharynx from behind. Now to have this view, what we have done is we have cut the pharyngeal wall at the median raphe, the midline pharyngeal raphe, and we have opened the posterior pharyngeal wall. So what you can see from behind, you can see the nasopharynx, you can see the oropharynx and the hypopharynx. Let's enlarge this image. Okay, once we have enlarged this image, what can we see? We can see over here the nasal terminates. See, from the posterior choana, you can see over here that there is a posterior choana on both the sides, and inside you can see the nasal terminates. Okay, the posterior end of middle and inferior terminates. What else can you see? On the sides, you can see the torus tubarius. That's the bulge of the cartilaginous part of eustachian tube. Come a little down and you can see the uvula. The soft palate and the uvula is hanging in the oropharynx. Then you can see the epiglottis. Okay, below that starts our hypopharynx. Okay, you can see the laryngeal inlet. So you can clearly see the larynx, you can see the laryngeal inlet, you can see that post-cricoid area, the posterior part of cricoid, that is the post-cricoid area, and around that we have the hypopharynx, right? Okay, and after the hypopharynx starts the esophagus, right? So let's look over here in this diagram. So I have further magnified that image and we can see the hypopharynx. Now let's look at this hypopharynx. Remember, the hypopharynx consists of three components. What are the three components of hypopharynx? Number one component of hypopharynx is the posterior pharyngeal wall. Okay, the first component is the posterior pharyngeal wall. The second component that you can see is the post-cricoid area. So anteriorly we have the post-cricoid area, that's the posterior part of larynx. You can see that post-cricoid area. Now, on the two sides of the larynx, okay, so I said hypopharynx is also around the larynx. So on the two sides of the larynx, you can see a fossa. This fossa is known as pyriform fossa. So that's the third component of hypopharynx, the pyriform fossa. Look in the pyriform fossa carefully. You can see over here a nerve crossing, that is your internal laryngeal nerve. So remember, this internal laryngeal nerve goes through the pyriform fossa into the larynx. Okay, so it supplies the supraglottis, it supplies the sensory supply to supraglottis, okay, and this is going through the pyriform fossa. Okay, so you have to anesthetize this. You can put a cotton pledget mixed with xylocaine over here and that will anesthetize this internal laryngeal nerve. Okay, so that is the pyriform fossa. Remember, pyriform fossa is a space and it is notorious among the smugglers. They sometimes try to hide diamonds in this pyriform fossa. Okay, and this is the place where the food may be struck or the saliva may be struck if there is obstruction in the post-cricoid area or in the esophagus, right? So these are the three components of the hypopharynx: posterior pharyngeal wall, post-cricoid area and pyriform fossa. Now, among these areas, the post-cricoid area, is the most significant area. Why? Why it is the most significant area? Because over here we have a syndrome that is known as Plummer-Vinson syndrome, also known as Peterson-Brown-Kelly syndrome. Okay, now this syndrome consists of three things. What are the three things? Number one, we have the post-cricoid webs. Okay, many books mention esophageal webs in the upper one-third of esophagus. They are actually post-cricoid webs. Number two, we have iron deficiency anemia. And number three, we have koilonychia, that is spoon-shaped nails. Now remember, the iron deficiency is very common in females. Okay, it is very common in females. Why? Because the iron is related to diet, and these females, they lose a lot of blood, especially the females in the reproductive age group. They lose a lot of blood during menstruation every month. Okay, so females, especially from low socioeconomic status. Okay, females from low socioeconomic status, and those low socioeconomic status females means they are generally in the developing countries. Okay, now in these females we have iron deficiency anemia, and that leads to colonychia. Colonychia is a presentation of iron deficiency anemia where we have spoon-shaped nails, and then there is post-cricoid webs. These post-cricoid webs leads to dysphagia that further aggravates the problem of iron deficiency anemia and more formation of webs. Okay, now this post-cricoid webs, remember, they are a pre-malignant condition, and they can lead to development of post-cricoid carcinoma. Okay, post-cricoid carcinoma is generally seen in females. It is generally seen in females of low socioeconomic status from the developing countries. So it is generally because of this, it's a sequelae of the Plummer-Vinson syndrome or the Peterson-Brown-Kelly syndrome. All right, so let's look over here. You can see the Plummer-Vinson syndrome. So we do a barium swallow, and in this barium swallow over here, you can see that there is a web, and because of web, there is a filling defect. Okay, so that is a Plummer-Vinson syndrome. Okay, it is at the level of C5, C6 vertebra. So that is the place where we have the cricoid. So that's the post-cricoid area, and that is forming the filling defect, and that denotes the Plummer-Vinson syndrome. Okay, now let us look at this question. A 70 years old patient, so you see 70 years old patient presented with history of fever, repeated aspiration and coughing in the night. All right, on examination there is a swelling on left side of neck which produces gurgling sound on compression. Okay, following is the barium swallow study of the patient. What is the most likely diagnosis? So what do you see? You see what do you see in the barium swallow? You see a pouch. This pouch is arising from the pharynx. It is behind the esophagus. It's a pharyngoesophageal pouch. And what is that pharyngoesophageal pouch? It is a case of Zenker's diverticulum. Right? Now, because there is food over here, when the patient goes to sleep in the night time, the food regurgitates back, and that presents as coughing in the night time. It irritates patient coughing. Okay, the food gets aspirated, so patient has repeated aspirations, and this repeated aspiration is also causing fever. Right? You can see that there is a swelling on the left side of the neck, which produces gurgling sound on compression. Remember that this pouch, you can press it. So when you press it, the food material in it will go out with a gurgling sound, and that gurgling sound is known as Boyce sign. Okay, so in the Zenker's diverticulum, we have a sign known as Boyce sign produced by the escape of food liquid materials. So that's a gurgling sound produced by the escape of food materials on compression. So this will be seen only when the pouch is big enough so that you can press it from outside. Right? Laryngocele we will discuss. You see the laryngocele we will discuss in the larynx. It has a totally different presentation. The Plummer-Vinson syndrome will not have a pouch, rather it will have a filling defect, as I just showed you in the previous X-ray. Okay, now the dysphagia lusoria. So let's talk about dysphagia lusoria. Now dysphagia lusoria is a congenital condition. Now what happens during development of the aortic arches? Let's say the proximal part of fourth arch disappears instead of the distal part. Now as a result of that, the right subclavian artery, so I'm talking about the right side, so let's say the right fourth arch, instead of the proximal part, normal the proximal part remains, the distal part disappears. Now let's say the proximal part disappears. Okay, now what happens? the right subclavian artery. Okay, this right subclavian artery, it will arise from the arch of aorta. Okay, so you see that this is the arch of aorta in this diagram. You can see the esophagus and the trachea, right? And you can see the aberrant right subclavian artery. Now this aberrant right subclavian artery is rising from the arch of aorta. Okay, and now this artery takes a turn. It goes behind the esophagus, okay, to the right side. So you can see this aberrant right subclavian artery, and then it will press the esophagus. So that will cause dysphagia. This is known as dysphagia lusoria. How can you confirm this? You can again confirm this by doing a barium swallow. So when you do a barium swallow, you will see the compression of the esophagus, okay, in the thorax. So this will be at the level of the thorax where the arch of aorta is there. The right subclavian artery will be crossing the esophagus. Okay, so that is dysphagia lusoria. It's a congenital condition. Next, we come to the carcinoma of the hypopharynx, CA hypopharynx. Now, CA hypopharynx, most common 60 to 70% arises from the pyriform fossa or the pyriform sinus, right? So that is the most common location for the formation of CA hypopharynx. Other than that, around 30 to 40% cases can arise from post-cricoid area. So post-cricoid area, as we discussed, is generally a sequelae of Plummer-Vinson syndrome. Okay, it rarely arises from the posterior pharyngeal wall. Now, how will it present? CA hypopharynx, how will it present? It presents with dysphagia. Patient is not able to swallow. Why? Because there is an obstruction in the digestive pathway. Other than that, patient can have pain in throat. Okay, patient may also have a feeling of foreign body or lump in the throat. Okay, this feeling of foreign body or a lump in the throat is known as globus feeling. Okay, so that is known as globus. Now there is a condition known as globus pharyngeus. So this condition is a feeling of lump in the throat without any actual problem. Okay, so that's known as globus pharyngeus. Now, otherwise patient can have a feeling of a lump in the throat in CA hypopharynx. So that's a known cause. When there is no organic cause, then we call it as globus pharyngeus. Okay, now what will you find on examination in CA hypopharynx? You see, number one, let's say it is a post-cricoid malignancy. So when you make a patient go supine, you take your thumb and your index finger, you make a U with it. So what I am doing, I am making a U, and you hold the larynx, and then you move the larynx to the side. So when you move the larynx on the vertebra, so patient has to be in supine. So when you move the larynx on the vertebra, you will feel a crepitus. Okay, this crepitus is known as post-cricoid crepitus. Okay, it is also known as Muir's crackle. Now, that is normally present. The post-cricoid crepitus or the Muir's crackle is normally present. Now, what happens if there is a post-cricoid malignancy? Now, if there is a post-cricoid malignancy, this post-cricoid crepitus will be absent. So, Muir's crackle will be absent. That is known as Moore sign or Boca sign. Now, you see, in the oropharynx, we discussed Irwin-Moore sign. Remember? In the oropharynx, we discussed Irwin-Moore sign. Okay, now we have discussed the Moore sign. So, just try to remember, how can we remember this? Irwin-Moore dealt with chronic tonsillitis. So, tonsils are two, right? Tonsils are two. Okay, chronic tonsillitis will have two tonsils right? We'll have two tonsils, two hypertrophy tonsils. So they appear like two O's. So the Irwin Moore with chronic tonsillitis, it has two O's, no confusion, right? In the Moore sign that we have just seen in the hypopharynx, you see absence of postcricoid capitis, we made a U. To hold the larynx, we made a U by the thumb and the index finger. Okay, so the Moore with the U is seen in the hypopharyngeal cancer. The Moore with the double O, that is seen in chronic tonsillitis. All right, so very easy to remember. Next, we can also see pooling of secretions in the pyriform sinus. Okay, that is because of the blockage of the digestive pathway. So that is known as Chevalier-Jackson sign, right? So this sign is known as Chevalier-Jackson sign. Now, the staging for carcinoma hypopharynx. So we'll discuss the T staging, N staging and M staging. I have already discussed when we talked about the CA nasopharynx. So N staging is common for all the head and neck malignancies except the nasopharynx, and we have discussed that. Okay, let us come to the T staging for CA hypopharynx. Okay, now the CA hypopharynx T staging, T1. What is T1? T1 means that the malignancy involves only one subsite of hypopharynx. Okay, so it can involve, there are three components, remember, there are three components. What are the three components? The three components are posterior pharyngeal wall, postcricoid area, and pyriform sinus. So any of these three components, one component, any one of these three components, all right, that is T1. Also the T1, the size should be less than 2 centimeters. Okay, now T2, you can say 2 to 4 centimeter. Okay, it involves more than one site. It involves more than one site. It may even involve larynx. Remember, the pyriform sinus, it may go to the larynx, but it should not affect the vocal fold mobility. Okay, if the vocal fold mobility is gone, then it is T3. Okay, so if the vocal fold mobility is gone, okay, this becomes fixed. The vocal folds, they become fixed, it is T3. Or T3 is more than 4 centimeter in size, or it goes and involves the esophagus. Okay, any of these is considered as T3. Right? T4. T4 you can divide into T4A and T4B. So very easy to remember T4A and T4B. Okay, T4A and T4B. Remember, T4, it goes into the neck. So it goes outside the pharynx, outside the larynx. It goes outside, that is T4. So for going outside, it can involve the different cartilages, thyroid, cricoid, it can go and involve the thyroid gland. All right, so it goes outside. Now, how we will say it is T4A or T4B? So very easy to remember. Let's look at T4B. So there are three places where if it goes, it will be known as T4B. Number one is the prevertebral space. Okay, so number one is the prevertebral space. Number two is the superior mediastinum. So it goes in the chest, superior mediastinum. And number three, it encases means completely surrounds. It completely surrounds carotid artery. Okay, so in this scenario, it will be T4B. Anywhere else in the neck, it will be T4A. So that's the T staging for CA hypopharynx. Okay, now treatment. The treatment, remember, CA hypopharynx does not carry a very good prognosis. Why? Because it is generally not detected in early stages. If it is detected in early stages, very early, small tumor, we may treat with radiotherapy. Okay, that will help us spare the larynx. But if larynx is involved, radiotherapy may not work always. Now, other than the early or the small tumors, Okay, for all the other, we nowadays prefer CCRT, concurrent chemoradiotherapy. So this is the treatment of choice. Okay, so this is the treatment of choice, concurrent chemoradiotherapy. Why do we don't like to go for surgery? We don't like to go for surgery because even for small lesions, we will have to do a big mutilating surgery. However, some surgeons, they do surgery, and surgery has to be followed by radiotherapy. Okay, so it is not, there is no study that says one is better over the other, but if you are given an option, you mark your answer as CCRT. That is a better answer over here. Okay, surgery we usually save for recurrence. After CCRT, still there is a recurrence. Okay, then we try to do surgery. So such a surgery is known as salvage surgery. Now what you have to do in this kind of surgery, you have to remove the entire larynx and you have to do a partial pharyngectomy also. Okay, so right, so you see over here the whole larynx has to be removed, some part of pharynx has to be removed. Sometimes you may have to remove the complete pharynx and you may have to do a esophageal pull-up also. Okay, sometimes you may have to reconstruct this pharynx with the help of sync flap over here like this. So you can repair with the help of free flap, right? So these kind of surgeries are generally big radical surgeries, and they are done only when you have tried CCRT and the patient has a recurrence. Okay, so let's look at this question. It was asked recently in the FMG August 2020 exam. A patient presents with carcinoma in piriform fossa. On laryngoscopy, right vocal folds not mobile. You see, so there is a carcinoma in the piriform fossa, that is clearly mentioned. Right vocal fold is not mobile. Okay, there is no lymph node involvement, no distant metastasis. What is the T and M staging? So we know vocal fold not mobile, it makes it as T3, no lymph node involvement N0, no distant metastasis M0. Okay, right, our answer is B, T3, N0, M0. Okay, so another question, patient with lump in throat with no difficulty in swallowing. So patient just has a feeling of lump in throat. There is no problem in swallowing or other problem. So we suspect a disease that I told you, it's more of a psychiatric disease that is known as globus pharyngeus. Patient is able to swallow. Okay, only feeling has a feeling of lump in throat. So that is your globus pharyngeus. Conditions such as CA hypopharynx, CA esophagus, CA pharyngeal pouch, all these, they have dysphagia as a prominent symptom. Okay, only place where there will be no difficulty in swallowing, that is globus pharyngeus. Okay, right. So that was our hypopharynx.